All right, guys, we are going to finish our lecture on the joints that we didn't get through here today. We're ready to talk about types of synovial joints. We just finished up talking about the movements that synovial joints perform. These are the different categories of synovial joints. First type we call planar joints, also known as gliding joints. Are joints in which the surface of the articulating bones are flat or slightly curved, which permits back and forth and side-to-side movements, which makes it biaxial. Remember, the prefix bi always means two, so allows motion in two axes. Back and forth, that's one axis, side to side is another axis. Examples would be the intercarpal joints. Remember, that's the joints that are in the wrist between wrist bones, like the scaphoid and the lunate. Intertarsal joints within the ankle, so like with the cuneiform bones. Sternoclavicular joints, which would be where the sternum and clavicle meet, and the acromioclavicular joints, where the acromion of the scapula and the clavicle meet. Hinge or ginglymus joint is where the convex surface of one bone fits into the concave surface of another, which produces an opening and closing motion like that of a hinged door. Hinge joints are how, you're going to need to know it. And they only permit flexion and extension, which is monaxial, one axis. Mono means one. And we have the knee and the elbow as examples of hinge joints. Pivot or trochoid joints are joints where the surface of one bone articulates with a ring formed partly by another bone, which permits pivotal movement, which is also monaxial, only one axis. Examples would be the radial ulnar joint, where the head of the radius rotates or pivots around in that space there with the ulna, allowing you to supinate and pronate, to turn your palms forward and backwards. And the atlantoaxial joint, which is in the head of the neck, allows you to shake your head no between the atlas C1 and the axis C2. Condyloid or ellipsoidal joints are where the convex oval-shaped projection of one bone fits into an oval-shaped depression of another. This is biaxial. So two axes, your wrist, or fancily your radiocarpal joint. The metacarpophalangeal joints, which would be where your knuckles are in your hand. So where your first phalange articulates with your hand bones, and it would allows you to wag your finger. Saddle or sellar joints are where the articular surface of one bone is saddle shaped, hence the name saddle. The articular surface of the other bone fits into that saddle, permitting side to side and up and down movements, but more freely than condyloid. So we call these triaxial. Tri is three axes. Another term we could use is multiaxial. Example of this would be your thumb, actually between the metacarpal of your thumb, so the hand on the thumb side, the hand bone on that thumb side, and the trapezium to allow you to twiddle. So, what we could do with other thumbs, which allows for opposition to occur that we talked about earlier. Ball and socket or spheroid joints are where you have the ball-like surface of one bone fitting into a cup-like depression of another. In the case of the picture here at the bottom is the head of the femur fitting in the acetabulum of the hip. Other example would be the shoulder joint between the humerus head and the glenoid cavity of the scapula, which is the most freely movable joint in the body. And these two types of ball and socket joints, hip and shoulder, are the most freely movable, permitting movement around all three axes and in all directions in between. So they're triaxial or multiaxial, as I stated just a second ago. As far as the pictures go, they just show examples, not something that you'll want to worry about studying for the exam. Now, the next several slides here to round us out in this lecture, we're going to go through specific joints, learn about their features and stuff like that. We have two tables here, one on this page 9.3 and then table 9.4, listing off selected joints. This table 9.3 is of the axial skeleton. Some of these we've talked about, like the suture joint, or sutures, I should say, and there's not just one. We just mentioned like the atlantoaxial joint. Some of these we haven't mentioned at all, but remember, a joint can be pretty dang simple where two bones meet each other, and in many of these cases, we actually see that as an example. Same thing, we talked more about some of these, what we call joints of the appendicular skeleton, the SC joint, sternoclavicular, AC joints, acromioclavicular, radiocarpal I just mentioned, which is the wrist. As far as the exam goes, don't worry about either of these two tables. I included them because they're in your textbook and there's a lot of information in them. They might be pertinent to something that you'll need down the line. Maybe if you go on into physical therapy school or want to be a chiropractor or something like that. But for the majority of us, people that want to be nurses and that kind of stuff, it's not super important to know about the carpometacarpal joint. So we'll kind of skip on past those and go through some of the most important joints of the body, starting with the TMJ, which we've talked about really kind of several points the last couple class periods. TMJ, short for temporomandibular joint, is a combined hinge and plane joint formed by the condylar processes of the mandible, or as we call them, the mandibular condyles, and the mandibular fossa and articular tubercle of the temporal bone. It is the only freely movable joint between our skull bones. It's what allows us to chew, grind up our food, and it even allows us to talk. Down here at the bottom, we have two pictures, a lateral view, so looking at kind of this side of the skull, and then a medial view. This would be like the inside of the mouth, and there's the teeth. This would be the inside of your jaw. Okay, so we can see some of these more internal ligaments. Okay. What we won't be able to see in either of those pictures is an articular disc or meniscus, which is a fibrocartilage disc separating the synovial cavity into superior and inferior compartments. And we can see the articular capsule, especially really well here in this lateral view. You can see a little bit of it here in the medial view, so you want to make sure you highlight that in both pictures. It is a thin, fairly loose envelope around the circumference of the joint. I would hope this would be common sense, but the lateral view is where you'll find the lateral ligament, okay, which is actually two short bands on the lateral surface of the capsule, extending inferiorly and posteriorly from the zygomatic process, that's the bridge, to the lateral and posterior aspect of our mandible to help strengthen the joint laterally and prevent displacement of the mandible. We don't see the lateral ligament in our medial view, which hopefully is common sense, hence the name. The next two ligaments are named for the bone that is associated with. The sphenomandibular ligament is associated with the sphenoid and the mandible. Stylomandibular ligament is associated with the mandible and the what we call styloid process of our temporal bone. And the styloid process, that little hook coming down kind of below the ear, where your ear would be right here. Stylomandibular ligament is a thickened band of fascia. It's again from the styloid process to the ramus of mandible, and it limits movement at the TMJ. We can see it down here as well. We can only see the sphenomandibular ligament here in our medial view, which you'll want to know as well. And that's because, the sphenoid bone is an internal bone for the most part, and it extends anteriorly from the sphenoid bone to the ramus of the mandible. So what's nice is everything that you need to know in these two pictures is already capitalized. So anything, like the sphenoid bone, styloid process, those are not fully capitalized, so don't worry about studying those. Okay, on to a very complicated joint, our shoulder, the true shoulder joint, as in the glenohumeral joint, which is where we have really great range of motion. We can, swing our arms around and wave them up and down, and all sorts of different things due to the interaction between that hemispherical head of the humerus articulating with the glenoid cavity or scapula. This is our most freely movable joint in the body. I've only included a anterior view. We could, look at things posteriorly,
could also look at things in many other views as well, but I'm kind of keeping it simple to make it easy on you guys. We'll start with the articular capsule, which is a thin, loose sac formed by the head of the humerus, extending from the glenoid cavity to the anatomical neck of the humerus. And it's labeled in this picture right down here, but to me that's like the dumbest spot ever to put it, because as you can see, it's all this white band of material right there behind this like blue bubble. So my advice would be to, draw the arrow, somewhere up in here. The glenoid labrum is another structure like the meniscus up here in the jaw that we aren't going to be able to see. If we wanted to see it, we'd have to remove the humerus completely. Okay? This is a ring of fibrocartilage that surrounds the glenoid cavity, so it's in the socket, providing a deeper socket for that shoulder joint. Not a structure that's so much for the GH joint, but it is a very prominent structure, and that is what we call your biceps brachii tendon. Biceps brachii, we know, is a prominent muscle that allows us to flex our elbow, flex the guns, we like to say. It is a two-headed muscle, as we'll kind of find more out about that in our next unit. But the tendon of that long head travels up from the biceps and actually travels past the shoulder joint on its way to insert in the superior margin of our glenoid cavity, meaning that it inserts on our scapula. Okay, it passes through that intertubercular groove, which is the groove between the greater, and you can't really see it, but the lesser tubercle will be right in there. Okay. So make sure you can highlight that, or do highlight that. In our next unit, we'll also talk more about the rotator cuff, a set of 4 muscles and their tendons that help kind of hold the head of the humerus in that socket. What we call the supraspinatus is a muscle, infraspinatus, teres minor. These 3 muscles are only visible if you were to look at a posterior view of the scapula and the humerus, because those are all found on the back side of the scapula. Okay. Your subscapularis muscle covers the front and the subscapular fossa of our scapula. What we see here in this illustration is its tendon. Okay. It's been cut away, but all of this would be covered, so that's why we cut it, so we can see this. So all you have left to show is that singular tendon, but the muscle will be very big in front, but it would be covering too much stuff. We'll talk, like I said, more about the rotator cuff in our next unit. Okay. We have several ligaments to talk about here for the next couple bullets. The coracohumeral ligament is a ligament shown here, and it's already listed all caps. That ligament there extends from the coracoid process, hence the name coracohumeral, to the greater tubercle of our humerus. The transverse humeral ligament is a ligament that connects the greater and lesser tubercles of our humerus, and it really helps kind of keep that biceps tendon from kind of pulling off of the bone. Keeps it nice and tight up against the humerus. And then the glenohumeral ligament, it's this ligament here, 3 thickenings of the articular capsule extending from the glenoid cavity to the lesser tubercle and neck of the humerus. And now we see several other ligaments like the coracoclavicular ligament, superior transverse scapular ligament. Those you do not need to worry about, because those ligaments, mainly all these right up in here, are not associated with the true shoulder joint. They're more associated with attaching the clavicle to the acromion of our scapula, forming that AC joint. If you go on into more advanced anatomy class, you'll probably have to know those, but for now, we'll keep it fairly simple. No, we're not done. We still have what we call bursae, which we learned earlier in the lecture, are the kind of sacs full of synovial fluid that help, in this case, the shoulder joint with reducing friction with all those tendons in there. We can't see all 4 of them, but we can see the subacromial, which you'll want to know, as well as the subscapular. What we would have to do is look on the backside to find the subdeltoid and the subcoracoid. So once again, make sure you have highlighted, if you haven't already, these three things, actually four things in a row that are all capitalized. The tendon of the subscapularis, the tendon of the biceps. I would move the articular capsule somewhere in here, and then the subscapular bursa. I would highlight that as well. Okay, moving on to the elbow. Now, like the shoulder, we can kind of point to three different joints when talking about the elbow as a whole. What we call the humeral ulnar joint would be what we would classify as the true elbow joint, and which you might want to write down. This is the hinge joint where the trochlea of the humerus joins with the trochlear notch of the ulna, enabling you to flex and extend your elbow. Okay. The humeral radial joint is probably the least important of the three joints here. It's just the point of attachment between the capitulum and the humerus, of the humerus, I should say, meet the head of the radius. The radial ulnar joint is the interaction of the radial head with the radial notch of the ulna. It says here not a hinge joint, but this is a very important joint because that's the one that allows you to supinate and pronate. Okay. In other words, remember to turn your palms forward or backwards, anterior, posterior. Okay, let's talk about our structures. First thing, you can see it in both images. It's a very distinctive, very prominent structure called the articular capsule. Articular capsule is on the anterior part, covering the anterior part of the elbow joint from the radial and coronoid fossa of the humerus to the coronoid process of the ulna and the annular ligament of the radius. Posterior part extends from the capitulum, olecranon fossa, lateral epicondyle of the humerus to the annular ligament of the radius, olecranon of the ulna, and the ulna posterior to the radial notch. Not that you had to worry about that, but I went ahead and read it for you. Okay, we have two very important ligaments on the side of the elbow, either medially or laterally, and they are named for the bone that they attach to. Now, it's important to kind of orient yourself medial lateral. We know that the ulna is pinky side, and the ulna is the bone that forms, our true kind of elbow point, as we like to call it. So we have a very good view here in our medial view of the ulna. We still see the ulna here in our lateral view, but if you watch and pay attention to which place, or which bone, I should say, the ligament goes, it'll be pretty easy to tell the ulnar from the radial. Okay? In fact, it's also super simple because remember, ulna is pinky side, so ulna is medial. With the ulnar collateral ligament, the UCL, as we like to abbreviate it, is only going to be visible in that medial view. Okay? This is the ligament that is damaged a lot of times in baseball players, especially pitchers, where they tear it from that repetitive motion that they do when they throw a ball, requiring a commonly called procedure called Tommy John surgery. The radial collateral ligament, this one here, attaches the humerus to the radius and is on the lateral side of your elbow, and therefore we can only see it in the lateral view or lateral aspect, as you see here. Final ligament we can see in both medial and lateral views is an annular ligament, which helps kind of circle around the radial head, attach at each end of the ulna to help hold the radial head against the ulna as we pronate and supinate. So everything that you need to know is already bolded for you in these two images, which is nice. Okay, moving down to the lower body, we're going to talk about the hip, and then we'll get into the knee and then the ankle. Your hip, also known as coxal joint, point where the head of the femur inserts into the acetabulum of the os coxae. We've got a anterior view, frontal view, where we've removed some muscles, just like the quad muscle, rectus femoris, out of the way. Same thing, we've removed a lot of muscles here in the posterior view, so we can see these. The articular capsule, very dense, strong capsule extending from the rim of the acetabulum to the neck of the femur. It's not something that you're going to have to worry about in this set of images. Okay. What you will also not have to worry about is the labrum inside of that acetabulum. This is a horseshoe-shaped ring of fibrocartilage increasing the rate and depth of the acetabulum. Can't see it because we have the femur inserted into that acetabulum. So what we have are 3 ligaments, the pubofemoral or pubofemoral, shown here in the anterior view, connecting the femur to the pubic region of our hip. Okay, we can't see it in our posterior view because the pubic portion of the hip is anterior. The iliofemoral is kind of this 2-part ligament that runs up and attaches more to the upper part or the iliac part of our hip, and you can see it in the posterior view, at least part of it. And then in the posterior view is where you can also find the ischiofemoral ligament connecting the femur to the ischium or the backside of your hip. Okay. Those ligaments are the strongest ligaments in the body, and when we stand up, they twist and pull the head of the femurs tightly into the acetabulum, making sure that we have great hip flexibility or stability, I should say. So, as far as the images go, you've got in all caps the things already labeled for you. Just 2 things in each picture, so hopefully nothing too crazy, too hard. Okay, probably the most complicated for what you guys will have to know will be your knee joint or tibiofemoral joint, primarily a hinge joint between the condyles of the femur and the condyles of the tibia. There is no complete articular capsule that unites the bones of the knee. The ligamentous sheath surrounding the joint consists mostly of tendons or their expansions. So we don't have it here in our anterior view. We don't show it in the superior view where the femur's been removed. We don't show it here in the posterior view, which is actually from a cadaver. This is probably the image that I'll focus on the most. It is an image looking at the front of the knee. What we've done is remove the patella from that patellar surface. It only looks like there's only a part of the femur like it's been cut off, but what's actually, this is a flexed knee. So what you can see, this will be the very end of your femur. You can see those condyles very nicely. The rest of the femur would be behind those condyles because it's in a horizontal position. So what we can't see would be that patellar tendon or patellar ligament either. A continuation of the common tendon of quadriceps femoris muscle extends from the patella to the tibial tuberosity, which we talked about. You can actually see a little bit of it here. Now, truly, it is a patellar ligament, but more than likely what you'll see it listed as is a patellar tendon. So I always tell students to kind of know and focus on it that way. Okay, between the tibia and the femur are 2 C-shaped, and you can see them really nicely here, which is kind of one of the main reasons I include this superior view, rings of fibrocartilage to prevent the big condyles of the femur from just pounding right down on the top of the tibia. Okay, we have what's called a lateral meniscus and a medial meniscus. Medial meniscus is a lot bigger, as you can kind of see, and this is actually the one that's more typically damaged when somebody has knee cartilage issues. Now, remembering back to our last lecture, we learned that the fibula was always lateral. So looking at the picture, you have to make sure you know which is the fibula, which is the tibia, which obviously they are big differences in size. That tells you that this portion of our picture is lateral and this portion is medial. So you can tell those 2 structures apart, which you'll have to know lateral and medial. Okay. That will also help you with the LCL, also known as the fibular collateral ligament, and the tibial collateral ligament, or MCL. Okay. My advice would be to at least in parentheses put, kind of in this space, LCL here, and here MCL, which is abbreviation for lateral collateral ligament, medial collateral ligament. Okay. The LCL connects the fibula to the femur to the fib, however you want to say it. MCL, also known as the tibial collateral ligament, connects the tibia to the femur, or vice versa, however you want to say it.
Function of these is prevent the knee from rotating when the joint is extended. And I'm not going to read through that, but it shows or explains where they exactly connect to the two bones. Now the C in MCL and LCL was short for collateral ligaments, okay, or collateral, I should say. The C for ACL and PCL is actually short for a term called cruciate, which translates to mean cross, which is what these two ligaments do. They form an X, and your knee, kind of in the very interior, they're intracapsular ligaments. Okay. The A for ACL stands for anterior cruciate ligament. Attaches to the anterior side of the tibia, whereas it attaches to the posterior side of the femur. So we can see the kind of top of it here in our posterior view. Here in our superior view, we can see part of it. It's been cut. Same thing for the PCL. But this is the ligament that prevents the knee from hyperextending, which happens to be one of the main reasons why people tear it, like when they jump and they come down with a leg that's straight and it bends backwards. That ACL a lot of times will rupture as a result. Also, it's fairly common to accidentally twist the knee, like football players, basketball players, when they're making a cut, that can cause it to become damaged. PCL, a lot less known about just because it's not as commonly injured. Short for posterior cruciate ligament, attaches to the backside or posterior side of the tibia. Then it comes forward and attaches to the anterior side of the femur. Its job is to prevent the femur from sliding off the front of the tibia. It happens, or it's damaged a lot of times in car accidents, and they actually call this a dashboard injury. Person is sitting like in the passenger seat, their legs bent, and they hit the dash like right there on the back of, or on the bottom side of their knee, pushing the tibia backwards, and the PCL will just rupture as a result. So yeah, you can see that one really nicely here in our posterior view. But as far as this page goes, this is going to be the image that you're going to want to focus on. And, that includes the things that are already all capitalized, with the exception, don't worry about transverse ligament of the knee, tibial tuberosity. That's not something that I'm going to focus on for this page. And then remember, be able to identify this as the LCL and the MCL. Okay, the last slide here is a slide that we're going to actually color because for whatever reason, there's just not any pictures of the ankle joint in your textbook. Ankle joint's also known as the talo or talocrural joint, and it's between the talus of your ankle and both the tib and the fib. So we learned previously the crural region is your lower leg, so that's where the term talocrural comes from, talus and lower leg. We've got 3 images here: posterior view, medial view, and a lateral view, and we've got 4-ish things to identify. First thing I'm going to color, and I'm going to actually just kind of combine these, what we call the anterior posterior tibiofibular ligaments, which just kind of help hold the tib and the fib together down there at the ankle joint. Posterior view is where we'll find the posterior tibiofibular ligament. Okay. And then here in our lateral view, we can see that posterior one again, but also the anterior one. So they just kind of help hold that joint together, those two bones together down there towards the bottom. All right, let's color the medial or deltoid ligament, which binds the tibia to the bones of the foot, preventing excess eversion. Remember, orient yourself. Tib is always medial, fib is always lateral. So now that you know tibia here is much bigger than the skin of your fibula, we know that these have to be the medial or deltoid ligaments, like so. And we also will obviously see them in the medial view. At least I would hope that would be common sense. We don't see them in the lateral view, but we do see what we call the lateral ligaments. There's actually kind of two of them, calcaneal fibular and the talofibular, which help hold the fibula to those various ankle bones. These happen to also be very commonly injured when somebody rolls their ankle, because a lot of times an ankle injury is a medial, or excuse me, an inversion ankle sprain, where their ankle rolls kind of inward, and that puts pressure on those and actually can cause them to rupture from time to time. Last thing is what we call the calcaneal or Achilles tendon, which really is not so much a structure associated with the joint, but it is a very prominent structure there. So I'm going to go ahead and color what it's done. It's been cut away. This connects to your big, what we call gastrocnemius muscle, your calf muscle, that we'll talk about in our next unit. Very, very strong tendon. Fortunately, it does rupture from time to time. And that should wrap us up here for our joints lecture. So I'm going to turn off the video.